Hey everyone, welcome back to another episode of the Brawn Body Health and Fitness Podcast. Joining me today is Dr. Petruccelli from the Greater Washington Orthopaedic Group. Dr. Petruccelli and I are going to be discussing rotator cuff injuries, how they happen, different types, surgical considerations. We also dive into rehab considerations as well. And then we also talk a little bit about the reverse total shoulder. This has been a game-changing surgery that Dr. Petruccelli has been performing, so we discussed that a little bit as well. I know you're going to love this episode. Be sure to subscribe and share this episode with a friend who you think could benefit from hearing this information. Enjoy. Dr. Petruccelli, super excited to chat with you today. Thank you so much for being here.
Yeah, thanks for having me.
For people who might not be familiar with you or your clinical practice, would you mind filling them in a little bit about who you are and all the things that you're doing?
So my name is Gabriel Petruccelli. I've been in practice for about 10 years, orthopedic surgeon, based out of the DC area. Came back to the area where I grew up in Montgomery County, which is about 20, 30 minutes outside of Washington, DC. Did my training in New York, residency in New York City, and then went to California to do my fellowship training in sports medicine. And I was out there. While we were out there, I worked with the San Diego Padres for that year, did spring training with them and the season. And then also worked with UCSD's athletics, mostly football, some other sports like soccer as well. So that was that year. And then we covered some other, some local high schools, junior colleges when I was there. Then I came back to the DC area and joined a group called the Greater Washington Orthopaedic Group, which has been a small group practice group that I've been in that's been around since I think it's almost 1980. It's been here for about 40 years. Multi-specialty. When I started, I think it was only 7 of us. Now I think we're up to 9 different docs, all different specialties. So my current role within the practice is, I do general orthopedics, but I'm trained in sports medicine, so I do a lot of sports medicine surgeries and see those types of patients. And then within sports medicine, we all kind of have a niche that we either truly enjoy or we like to kind of subspecialize in. And shoulders is definitely something that I have a really big interest in. Within, the realm of sports medicine, I think there's some docs out there that kind of pick a joint that they like to replace. A lot of sports doctors will do partial knee replacements or full knee replacements. Well, I picked the shoulder. I've always had a pretty big interest in shoulder arthroplasty, and my fellowship, a lot of it was spent doing that. So I kind of brought that to my practice here. So I do a lot of our shoulder arthroplasty. And at the same time, I take care of a local high school, a all boys Jesuit high school called Georgetown Prep. There's 2 team doctors. I'm one of their team physicians, and I've been doing that since I've been in practice for 10 years now. So thanks for having me.
Yeah, that's awesome. And as you mentioned, your experience really focuses in on the shoulder, and I'm super excited to talk with you about that today. And that's where I first heard about you, is your skill in surgical management of complex shoulder cases from some of our mutual friends there. For just kind of starting off here, when it comes to the shoulder, just kind of general anatomy, what are we typically looking at when we think about that joint there from your angle, Dr. Petruccelli?
Yeah, so the shoulder is a pretty complex joint in the sense of it's not kind of your normal ball and socket joint that most people think of when they think of the hip, for example. And what makes it pretty unique is that it's made up of the scapula, which is the shoulder blade, made up of the clavicle, which is the collarbone, and it's made up of the humerus, the proximal humerus, which is the top part of your arm. And so where they all come together, where they meet together, all 3 of those, is considered the shoulder joint. The shoulder joint that people think of that moves is really the proximal humerus or the ball articulating on the glenoid or the socket. And so what's interesting is that when you really take away all of the soft tissue of the shoulder and look at the just the bony structure or architecture, it's really more like a ball on a plate or ball on a saucer, or for some patients, I kind of explain it's like a ball on a golf tee. So you got this really kind of large ball on a smaller plate, and what really kind of then makes up the socket, if you want to think of a socket, is the rotator cuff tendons or muscles, which kind of wrap around. A lot of people call it the rotator cuff. And I think it's because it's, people say it quickly and that's kind of what they hear, but it's really a cuff, like a cuff around your shirt. And so there's 4 of them, and they kind of wrap around almost, 360 degrees. At the bottom part, they don't as much, but wrap around the shoulder. And that really provides both, stability in the shoulder, and obviously allows the shoulder to be moved in different directions. So it provides what I call dynamic stability. So, the layers of the shoulder, I explain to patients, the most outside layer is the deltoid, the big muscle that wraps around on the outside part of your shoulder, followed by the pec in the front, and, your lat towards the back, which wraps around in the front as well. And then you peel that away, and you're looking at the rotator cuff tendons, those 4 from front to back. And then underneath that is the capsule or the ligament of the shoulder, which then, attaches to the labrum, which the labrum is wrapping around that golf tee. So if you think of a golf tee, or if you think of like a 6-pack of Coke, and you got like the plastic ring around, well, the can itself is the glenoid, and then the labrum is that plastic ring around, kind of makes it a little bit wider, right? And then off that labrum comes your ligaments, which attaches to the ball. So that's really the kind of the general anatomy. It's not a true ball and socket. It does allow, because you have this large ball on a small plate, so to speak. It does allow for as a range of motion that is unlike any other really joint in the body. So that's kind of the general anatomy. And I guess we're going to get into a little bit of kind of some of the injuries we see around the rotator cuff itself.
Yeah, definitely. Fill me in a little bit about that, Dr. Petruccelli. You mentioned that the rotator cuff tendons especially play such an essential role in providing dynamic support and stability to the shoulder as we move throughout our range there. They really help to add an extra layer of duct tape, for lack of a better way to put it. But as you and I both know probably a little too well, we see a lot of people who end up injuring one or multiple rotator cuff tendons. So, when that happens, what kind of things are you looking at clinically? And, does it vary or differ between which tendon is injured or when multiple are injured in an individual?
Yeah, absolutely. So, clinical presentation for rotator cuff injury, and when I say that, or when I talk about that, it's really a spectrum of injury. So you're talking, the inflammatory tendonitis stage, which can, lead to some of the bursitis, which is kind of on one end, all the way to these massive, and what I mean by massive is large rotator cuff tears that are so far pulled away from the ball itself and retracted and atrophy that repairing them is unable to be done. And those patients end up with a, no longer real fulcrum of the shoulder, and the shoulder doesn't move the way it needs to. And those patients can end up with what's called rotator cuff arthropathy or arthritis due to the rotator cuff no longer functioning. So that spectrum presents in my practice in many different ways. It's either degenerative, meaning it's kind of happening over time, or it's acute. So really, when I think about a rotator cuff injury and patients come in, it's one of the first questions, as doing what you do, is how did this happen? And classically, it's either going to be like, I fell off a ladder, I was falling down the stairs and I grabbed the railing on the way down, or it's going to say, I don't know, like I've kind of noticed some pain, and a lot of times they'll point to over their deltoid. It's just been kind of progressing and getting worse. So really, in my mind, I kind of go, as we do often with diagnoses, I go through an algorithm and I start with how did this begin and how did it present. We do know that rotator cuff tears happen, it's wear and tear. It happens as we start to age. And there are a significant portion of patients that have what we call asymptomatic rotator cuff tears that, I'll get an MRI or a primary care doctor will send somebody for an MRI for some reason, not knowing what they're looking for. And the patient will come back in with an MRI that shows they have a rotator cuff tear, but they have no pain. They had pain previously, and they're asymptomatic, and those we treat differently. So to answer your question, really, I look at these when patients come in as either degenerative or acute. And generally it's going to be, often after the age of 40, we start seeing more of these.
Yeah, and I would definitely see, at least from my end, I see a lot more males than females with this kind of injury in general, I would say.
Yeah.
Do you see something similar?
I do. I don't know if there's really any data to support that, but I would say in my practice, I probably see more males with rotator cuff tears. Yeah.
Yeah. And, I think it's interesting too, because I haven't really seen like a great pattern as to why one tendon is injured over another. I think supraspinatus is probably the most common full thickness tear I see.
It is.
But after that, I've seen a little bit of everything. I've seen some full thickness subscap tears. I've seen some full thickness infra tears. Like I've seen kind of a little bit of a mix of those, and I haven't really found a great like pattern to them unless someone has a significant past sporting history, like maybe they played baseball for 20 years or something along those lines.
Yeah. I would say the most common I see, especially with degenerative tears, is going to be the supraspinatus, extending sometimes to the upper subscap area, which we know is, confluent there when it kind of crosses where the biceps tendon is. So that's what I would say is probably the most common degenerative tears I see. If you're talking about like an acute avulsive, tear, I've seen, subscaps and supraspinatus as well. And of course, I kind of look at it as, you're looking at kind of a starting point, right? So I kind of explain to patients, if you have a starting point, a little bit like a meniscus, if you have a place, like a piece of paper is starting to tear, and that's the beginning of a tear, if you leave that piece of paper in the corner and don't move it, it's probably hopefully going to stay that way. But if you throw it out in the wind and it starts pulling every different direction, that's a starting point and the tear can propagate. So, you could see these tears start in one area and propagate to the back or to the front.
Yeah, definitely. And do you think, or do you see a lot of correlation between rotator cuff tears and other pre-existing shoulder pathologies? So maybe someone had like, an impingement syndrome, or maybe someone had like past issues with like shoulder labrum or something like that. Do you see a lot of correlation between other shoulder pathologies and rotator cuff deficiency, I'll say?
So I do see it, with other shoulder pathology, most notably biceps pathology. That's probably the most common thing I see it with, as well as, some type of acromion, either impingement syndrome or acromial pathology. Whether it's a hooked acromion due to normal morphology of the patient. Patients come in and, it's kind of normal to them, the way the acromion is shaped, which can lead to, impingement syndrome. And then there's some patients that have more of, what we call a spurring, and it can be because of calcification of the CA ligament. And that's due to maybe more chronic high riding, insufficient rotator cuff injuries that led to kind of this calcification. And then, of course, you see, patients with calcific tendonitis, which, I don't generally see a lot of calcific tendonitis that has then led to like full thickness tears, but we do know it can sometimes happen over time. And sometimes often when you're treating calcific tendonitis, which is not often treated surgically, but when you do, sometimes it needs to be debrided and you end up, causing, a full thickness tear that needs to be fixed. So I would say biceps pathology and acromion pathology are the most common things I see with rotator cuff tears.
I think it's interesting that you mentioned the biceps pathology in particular, because I've been reading some literature lately that's kind of proposing the biceps as almost like a fifth rotator cuff muscle, if you will, for, additional stability on the anterior aspect of the, glenohumeral joint there. What are your thoughts on that?
Yeah,
With the biceps?
It's interesting because so when I started training, or as the latter part of my training, going from residency to fellowship, we were taking care of biceps, or biceps pathology with almost every rotator cuff tear we were taking care of. And so I look at the biceps a little differently than maybe somebody, 20 years older, perhaps maybe that trained differently. But I really, really give a good long hard look at the biceps when I'm operating on the rotator cuff, because I do think there's a lot of pathology within the biceps that can lead to further pain. Number one. Number two, I think sometimes it's also a space situation. And when you're going in to fix a rotator cuff, sometimes the biceps is in the way, there might be some pinching. So you get to the point where you feel like you kind of have to move that out of the way to get a good rotator cuff repair. And the other thing too is, that anatomically, the anterior supraspinatus and and the superior border of the subscap is right where that biceps is kind of wrapping around. So if you know there's some diseased tendon in that area, what's to say that it's not, involving that top part of the biceps? And so I really address biceps. Now, the way to address it, biceps anatomy versus tenodesis, that's a debate that we can have forever. But, when I was in fellowship, we were just taught to really look at the biceps and get a good idea if you think this patient is going to benefit from addressing it. And quite often I do. I mean, it's rare that I'm not, maybe in a younger patient, but in an older patient, I don't want to have any reason for residual pain after rotator cuff repair. And biceps can be one of them.
Yeah, no, I love that point. And, I think it's often overlooked to the role it plays at the shoulder. Everyone just thinks about it as, the role it plays at the elbow, bend the elbow, supinate the elbow. But the fact that it crosses the shoulder joint, I love that you bring up the importance of addressing that as well.
Yeah. And what's interesting, not to cut you off, is that, it's conceptually, it's kind of hard for patients as well, right? Because they're coming in for their shoulder. And when you start describing kind of a secondary operation in regards to their rotator cuff, you have to really, I have a shoulder model that I take in all my rooms, because if you don't explain that to patients, some of them don't understand it. Like you said, they think your biceps just, flexes your elbow or supinates your forearm. Like they're not knowledgeable in that regard. And so it's important you really explain the anatomy to them and understand that also there's two heads of the bicep. One's kind of in the shoulder joint, one's outside the shoulder joint. Doing a tenotomy versus tenodesis and kind of explaining to them why you're doing it. But I think that is really important to explain.
It's also one of my favorite things to address with patients in PT as well is, hey, if we just crush arm farm for like 20, 30 minutes and blow up your biceps, magically your shoulder gets better. And for some reason, I don't have an issue convincing people to do more bicep work.
Right.
That's crazy. But as you were talking there, you kind of mentioned about different surgical considerations. And, I think the first question I've got to address with you is what would lead you to operate on a rotator cuff tear in the first place? I've seen individuals with partial thickness tears, full thickness tears, some with full thickness tears function normally. Some with full thickness tears can't lift their arm more than 20 or 30 degrees. So what kind of things are you looking at to determine, what goes into your surgical considerations that way?
Okay, that's a good question. That's something that comes with, I think, experience with talking to patients and, kind of having an algorithm in your head that, doesn't work for everybody, but for most patients when the patient walks in. So what do I consider first and foremost is how the tear happened. Did you fall or has it been there? I think that, if you look at a rotator cuff tendon tear from an acute injury, on Monday they were fine. And then on Tuesday morning they fell. And on Wednesday they came in to see you and they can't lift their arm up. I'm going to look at that differently than somebody who says, hey, Monday it's been bothering me, or, 5 weeks ago it started bothering me. I can still move my arm, but it really hurts to move it. I'm going to look at those patients totally different. So the acute tears almost always, there is some consideration in which I don't treat acute tears the same, but for most acute tendon tears that come in, if their pain is significant and their function has been significantly decreased, and I know it's acute tear, they're generally leaving with a prescription for an MRI, confirmed on MRI, and then I sit down and talk to them about fixing it. And of course, I always go over, obviously the risks of fixing versus not fixing, taking their age into consideration, their hand dominance, their lifestyle in terms of activity and work, and then have a discussion with them. But for the acute tears, almost all of those are getting fixed, small versus large. For the acute tear that is more an acute on chronic tear, meaning they were the patient that said, this has been bothering me for a couple months or a couple years, but I was doing okay. And then they end up having a fall and acute on chronic tear. And I get an MRI on that patient that shows significant retraction, significant atrophy, and I know that they aren't going to do well with a repair. I will put them in physical therapy and see how they respond. If they don't do well, you talk about surgery with them, but for that patient, hopefully they're older, there's a different type of operation for that patient, like a reverse total shoulder, which we can maybe discuss a little bit later. So the acute tears I generally treat surgically. The more degenerative tears, I really have a long conversation. A lot of patients come in, with, let's talk about how they present. A lot of them will say, I have pain with forward elevation, lifting, their arm up in front of them, reaching up on the countertop into a cabinet. Hurts when I go behind my back, women buckling, snapping the bra, men putting their wallet in their pocket. Maybe, it hurts to reach, outwards with their arms straight out. And it's been there for a while. And generally they will complain of pain with range of motion, but they'll also complain of pain. A lot of times they're complaining of pain right over the deltoid. And we know, the inflammation, the bursitis is going to kind of lead to that referred pain. I've actually had some patients say, the pain's right here, and they're pointing kind of at the deltoid insertion. And, they swear to me it's coming from here. And I keep explaining to them it's coming more from your rotator cuff. Sometimes it is coming from that, but most of the time it's coming from the rotator cuff. So those more degenerative tears, when I see those, it's more about a conversation of how long it's been there, how big the tear is, how are they functioning, have they tried conservative management, like modifying their activity, starting physical therapy, and then maybe having a conversation about injections. So I really, to go back to your question, acute versus degenerative to me are treated differently from kind of the get-go.
Yeah, I like that split, and I kind of like that thought process that you walked through there in how you would determine whether or not someone is a surgical candidate. And I also love to hear that, you're not like pushing everyone right into surgery. Sometimes there's a time and a place for conservative management. And I think that's very, I'll say, rare to hear from someone who makes a majority of their money, I'm assuming, from doing surgery.
Yeah. Well, I mean, I think personally, what makes a good surgeon is knowing when not to operate. So, and when we are here as we have tools to help you, but there are 100 other tools that might help you that we can try first, because there are risks with with operative intervention, of course, and sometimes it's unnecessary. The other thing too is a lot of times patients will come to me with, back to the first question about the degenerative tears. Patients are coming to me saying, hey, I'm in pain, and asking them when, and a lot of times it's at night. So when patients end up with a lot of night pain, sometimes that will be the defining moment for the patient to make the decision about surgery versus non-surgery. Because once it starts affecting patients' sleep, it turns into, if it affects my sleep, then it affects my day, which affects my work. And so that's a big complaint I get from patients about nighttime pain, which can often lead to an operation.
Yeah, no, I think that's a great point to bring up as well. And, to your point as well, you mentioned there's hundreds, if not thousands, of different tools and things out there that exist to kind of help us get back to where we want to be from a pain and functional level. And I'd say the same goes for you as a surgeon. When you are looking to operate on someone's rotator cuff, you can do a variety of different approaches or options and that sort of thing. And I'm curious to hear your thoughts on, do you tend to go more like an arthroscopic repair or more of like a fully open repair? And what might kind of point you to do one versus the other?
So I think a lot of it is training. I think that a very good mini open repair is comparable to an arthroscopic repair in the right hands. I trained within the last 15 years. And so doing these mini open repairs didn't really exist until they existed more in the earlier part of my residency training, in which we were there were some docs that were doing one way, and then we're learning it arthroscopically. And then I got the fellowship and everything was done arthroscopic. I think in the situation with almost all rotator cuff tears, for me, they can be treated arthroscopically. And I'll get into that in a second as to kind of why I think arthroscopically, is advantageous versus a mini open in certain specific situations. The only time I would say maybe an open would kind of make more sense would be if you had a really large, full thickness from top to bottom, superior to inferior subscap repair that's retracted. So in that case, maybe an open repair would be helpful. But for the most part, I would say, almost all the time I'm getting, my repairs, they're done, arthroscopically. I do think that having a camera, you can kind of look into areas that you can't necessarily look, with, naked eye, clean out areas, clean out the bursa. put things down on the footprint and put it down where you think it needs to be. And so in my hands, arthroscopic is how I fix mine. Yeah.
Yeah, no, that's really interesting. And it's always been something I've kind of wondered, because I've seen various types of incisions and sizes of incisions in patients over the past year that way. And I've noticed that the newer incisions are definitely getting smaller and smaller, and what they're able to fix through those things is getting more and more significant. So it's impressive that you're able to do everything like that through really just like 2 or 3 small incisions most of the time.
Yeah, and patients seem to be often amazed by it as well. And when you kind of show them how it's done, with these small instruments, it is we've come a very long way, and not only has the way we're doing them changed, but the instruments in which we use to do it, and then of course the implants in which we use as well, have just in the last 10 years, and me doing them arthroscopically have changed as well, which is quite interesting. And it's great to see the innovation that's going to kind of happen over the next probably 20 to 25 years of me being in practice.
Yeah, definitely. Now, on the rehab side for a second there, when it comes to the rotator cuff injuries, post-operatively especially, I've found, at least from my angle, it's really good to trust the process and be patient with it. I have not found much benefit, if any, from being aggressive and pushing on it really hard and heavy. And I've kind of found a lot of value myself in just kind of trusting the process of, slow but consistent range of motion gains, slow but consistent strength gains. Does that sound kind of typical for what you look at from a PT, or what kind of things do you usually look for from the PTs who are rehabbing some of your patients post-operatively?
Yeah. So, one of the things I get, I have a pretty conservative approach to shoulder PT. We do know that, early range of motion, after these repairs, can lead to kind of an increased range of motion earlier on. But at the end, 1 year later, with the ones that are restricted in terms of range of motion, let's say for 6 weeks, we'll end up at the same place. So you're kind of doing this, right? So you're kind of like, you're both coming from different directions, but at the end, you're going to end up at the same point. So I tailor my PT instructions based on a couple things. The patient itself, and you get an idea as the physician, which patients you think are going to be, super stiff, not all the time, but often, super stiff. They're not going to want to move it. They have, a higher chance of going on to having a stiff or frozen shoulder. And then you have some patients that think, okay, he fixed my rotator cuff, I'm ready to go back and throw a baseball tomorrow. Like, they kind of have the other end of the spectrum, which thinks that if this thing's back down, I'm good to go. And I kind of explain to patients, like, look, if I wanted to glue a piece of paper to the wall, right, and I put the piece of paper on the wall, I put my hand up, if I take my hand away right away, it's going to just, fall right off the wall, right? So you got to apply pressure. You got to let it sit and let it start to heal before you take your hand away. And so when you tell patients, you've had a repair, but you now need to let it heal, they need to understand that, and understand that there's a process, like you said, that you need to trust to kind of get to where you need to be. So my kind of standard PT protocol for these patients for rotator cuff repairs is I do active range of motion of the fingers on the hand. The elbow range of motion is all dependent on, biceps. If I did a tenodesis or tenotomy, and if I did subpec tenodesis, is sometimes what I do. But so elbows, active or passive, depending on what I do. And then shoulder, I do strict passive range of motion of the shoulder for 6 weeks. And I start most of my patients at 2 weeks post-operatively with passive range of motion of the shoulder only. One of the things I get concerned with is that patients, when you have a hip replacement, right? You got somebody comes to your house day 2, they explain to you what you can and can't do. When you have a shoulder surgery, like a rotator cuff repair, these patients wake up, they're wearing an abduction sling. Quite often they're not getting any instructions from, and I call all of my patients the next day to kind of explain to them a lot of what we did and what to do. But a lot of times they're not getting any instructions. So they wake up with the sling on, they got a shirt over their arm, and they don't know what to do. And what I usually tell my patients when I call them, I say, look, whatever you were kind of wearing, just kind of keep the sling close to your body, put the arm put your sweater over the arm, keep the arm kind of on the inside. And when you come in next week, I'll show you how to take the sling on and off. I'll tell you how to put a shirt on and off, because I think a lot of times those earlier, kind of stages of the repair itself can lead to patients doing too much because they don't have any idea of, how to move it. And so when I have a really massive tear that I take care of, and I think that they have a chance of, doing something that's not smart, I tell them just keep it the way it is until you see me back. These smaller tears that I know are going to hold real well, I'll see them back. I'll say start PT, within 10 to 14 days. And then those massive ones, I may, hold them off about 2 weeks. After 6 weeks of passive range of motion, I then move to active assist range of motion. So I let them kind of use it, with the assistance of the other arm. Now, again, this as a therapist, that everything you tell a patient, they're going to do a little bit more than that. So I'd much rather start with being super conservative and tell them they can and can't do things than telling them you can do a lot more and they do even more than that. So I do active assist for about 4 weeks after that. And then at 10 weeks, and I know you may say this is really conservative, but at 10 weeks, I start active range of motion. And then at 12 weeks, I start strengthening really light with bands. And then, clearance for, kind of, me saying return to everything you want to do is all dependent on that repair and how big it was, the tear itself. That could be as quick as 6 months. It could take up to a year, also dependent on age. So I think I have a pretty conservative protocol. We have a therapist in our office that sees a lot of my shoulder patients. And when you have somebody you've been working with for a long time, a doctor or a therapist, vice versa, they kind of know how much to push, and how much not to push. And they understand what you expect to see on their post-op visits, And then when the patients come in, if I have some patients that are like really, it's kind of loose, more loose than it should be, I kind of tell them you need to slow down. Or if they come in and they're super stiff, I kind of, I'll start to be a little bit more aggressive, So when I see them back the first week, I will make that call as to what to do in terms of their protocol. And I explain to them this, because when you explain a lot of your protocols to patients, either right after surgery to their family member, they're not going to remember. Or if you explain it to them before surgery, nobody thinks about their rehab unless the patient has already had prehab. Some of these patients that have exhausted physical therapy prior to surgery, that's one of the reasons why I actually like therapy for a lot of these degenerative tears that go on to needing surgery, is because they'll get into your office and they're there and they know where everything is. They know where the bands are, the rollers are, they know everything. And so that's good. They have an idea of what to expect over that next several months.
Yeah, definitely. I completely agree. And I love your point there on the slow and steady. And, I think we have this conversation mostly with the ACL on the podcast, but certainly holds true with the rotator cuff is, there's always that one person who just wants to cut a corner and get it done quicker, or, do the express rehab or the accelerated protocol. And it's like, look, that might not really get you where you want to be, Yep. If you don't give it time to fully return to a full level of strength and also strengthen yourself beyond where you were in the past, I think you're ultimately predisposing yourself to additional injury risk. And I also think that sometimes tissue just takes time to heal. I love the criterion-based progressions, but we also have to keep in mind that, we really can't accelerate the body's healing rate. So, with something like a soft tissue tendon at the shoulder joint, especially if it's someone, in that 40, 50, 60-year-old male range, we start to see a little less, vascularity in that area. We start to see a little bit more of a blunted healing response. We might need that additional time, I think. So I'm a huge fan of the conservative route. And I'm also a huge fan of just in general testing, not guessing when it comes to the post-op. So if it's a range of motion thing, don't just eyeball it. I know the goniometers aren't perfect. I have my gripes about them myself, but, actually take the time to measure and make sure you're hitting the goals that you want to. Same thing with like end range, return to sport type stuff. Like, don't just assume it's strong enough, like actually get some numbers and assess how strong it actually is before someone goes back, because I'm sure as well as I do, once you tell someone they're good to go, you're not seeing them again.
Exactly right. You're exactly right. And this is kind of what I was talking about. I always tell patients with my rotator cuff repairs, I say, or for a lot of my shoulder surgeries in general, I say the three times I see patients mess it up the most is week 1, week 6, and month 3. And week 1 because they're back for their 1 week follow up, and it's the patient that thinks, okay, I had surgery, I'm good to go. Thank you very much. I'll see you later. And I say it's not how it works. And then week 6 is because that's when the sling comes off. So in their head, they're saying, sling's off, I'm good to go. I can do whatever I want. And then I see, injury again at month 3 because they are now starting the strengthening phase. They kind of forgot a little bit that they had an operation. They're kind of coming out, on the other side feeling better. And so they think they can kind of return to most activity. So I really caution patients at week 1, week 6, and month 3 to really understand that this is, like you said, we know this takes time to heal. You're generally not going to be different than the next person. And just, let the process kind of move through what it needs to move through to get to where you need to be,
Yeah, exactly. And not to mention, having multiple shoulder surgeries or shoulder injuries, the more you go in and, for lack of a better way to put it, cut things or repair things, the more you're going to develop, what do we want to call it? Age-related changes, maybe, of the joint. And that might predispose you to earlier onset of shoulder arthritis, or just put you at an increased risk for developing it in the first place. And as you mentioned previously, you're a huge fan of the reverse total shoulder for individuals who are rotator cuff deficient, for a alternative option, especially if it's been a chronic tear and they've seen a significant amount of atrophy. So would you mind just taking a couple minutes and walking us through what is so unique about the reverse total shoulder and what has made that kind of stand out for you as something that's been so successful from your eyes?
Yeah, this is a wonderful operation that has really kind of changed the game of shoulder surgery in the last 20 years or so, in regards to kind of the mechanics of the shoulder. And when you look at, again, this is it. I love models. I think, showing models to patients really kind of, they understand it. They understand the mechanics of it. And when you look at the shoulder and you think at the ball on the golf tee, if there's no force coupling, so if the rotator cuff muscles are torn, and I'm only going to kind of explain how a reverse shoulder replacement works in kind of that regard, because it works for severe arthritis for other reasons, but we're going to talk about it in regards to rotator cuff. But when you look at the force coupling of the shoulder, so you have the subscap in the front, the infra and teres in the back, and those are kind of pulling together and force coupling the proximal humerus to the glenoid itself. That's what kind of keeps that fulcrum, right? So when you go to move the shoulder, it keeps it centered, and you can kind of move it in different ways. When you lose that force coupling, and the shoulder starts to kind of ride up or become what's called high riding, the shoulder, the proximal humerus abuts the acromion. So when you go to lift your arm up, it kind of hits the top of the acromion, and you have a really hard time, elevating because that fulcrum has been lost. So for these rotator cuff tears that in the past had been torn for a very long time, and had just been degenerative over the years, become atrophied, fatty infiltrated, and were irreparable, those patients would come in with very limited function, and sometimes with a lot of pain, and they would, wonder what's going on. And you say, you kind of lost the architecture of the shoulder that kind of keeps it in place. And there's really nothing we can do for you. You can give injections to help with the pain. We can maybe get you into therapy to work on the, scapular stabilization and kind of see if you can kind of force the shoulder in a way that's hard. But for the most part, you wouldn't be able to do much for them. And then came this prosthesis, arthroplasty, this prosthesis called the reverse total shoulder. And it's kind of an interesting name because, it is really reversed. The ball's on one side, the socket's on one side when you talk about the reverse. The problem with the reverse total shoulder is, while it's an amazing implant that has done so much for so many people, the term itself, sometimes is a little bit of a misnomer for patients because they don't want things backwards. They rather call it like the super duper shoulder or something, but not the reverse. Because when you tell patients you need this, like, I don't know if I want that, but what essentially is happening is that if your ball and socket are on one side and you go to lift your arm up and you have no rotator cuff and it's kind of sliding up, what you're doing now is you're putting the socket on the proximal humerus side, okay? And on the glenoid side, you're putting a ball. It kind of comes out like this. And now what happens is that when you go to lift your arm up, it uses the, articulation between the glenosphere, which is the ball, and the poly, which is the socket or the tray, and it allows it to kind of rotate and move along this, what I tell patients, kind of like a track, right? So it's like, it's sitting on a track, and it allows you now to move the shoulder in different directions. Now, what's amazing about this is that this gives many patients who have very, very poor function a lot of function back, everyday function, combing their hair, brushing their teeth. I had one guy could not even reach out to shake somebody's hand. He would kind of lean into it with his body to get his hand close. And I did this on, and just that simple thing that you kind of take for granted, you couldn't do. And so it gives a lot of people a lot of function back. One of the things I really explain to patients, because some patients come in with large rotator cuff tears, with amazing range of motion, maybe a little bit of pain, but they were told by their primary care doctor, you have a very large rotator cuff tear, and what should I do about it? And I tell patients nothing. And they're saying, well, I've heard that, when you have these large rotator cuff tears, you can have a reverse total shoulder. And I really explained that the reverse total shoulder is really utilized for these patients that have really, not terrible function, but really limited function. Some of them have terrible function. And so if you have really good motion and you come in and no arthritis, but a large rotator cuff, but you can move your shoulder pretty well, a reverse total shoulder might actually make you lose motion because it's on a track, right? And so they might lose some motion, they might not be happy. So this is really what I call a salvage procedure for those older, not necessarily totally low demand, but older patients that have these chronic rotator cuff tears with limited function and also with pain. So those same patients who have those large rotator cuff tears that are retracted and irreparable, as the shoulder starts to kind of move in different directions and it's not sitting where it needs to sit, the cartilage in the shoulder is not, the wear pattern of the cartilage is not equal, or sometimes it is equal, but it's wearing out more. And those patients can end up with what's called rotator cuff arthropathy, in which the rotator cuff tear has now led to the wear and tear of the cartilage. And those patients, the patients with the limited function and arthritis, who end up with a reverse total shoulder, do very, very well. I mean, it's probably one of my favorite operations because in such a short time, a lot of patients gain a lot of function back and are generally doing very well in terms of pain. So that's kind of nuts and bolts of it. Hopefully it's you can understand the explanation without really a video. But for people listening, if you've never seen how a reverse total shoulder works, you can just type it into Google and look it up and see. It's a really amazing operation, which has been tried and tested over the years with many failures and different implants, and we're continuing to perfect this in many different ways. Patient specific instrumentation. It's a great operation.
I would assume it relies mostly on the deltoid for most major movements of the shoulder as a result of the rotator cuff insufficiency, correct?
Yeah, very good point. So if patients have, non-functioning deltoid for, let's say, a nerve injury, let's say axillary nerve has been injured and their deltoid's not firing, then they're not a candidate for that operation. So definitely need a good firing deltoid for this operation to work.
Right. And I guess I would ask, do you do like a pre-op PT deltoid strengthening, or do you see any kind of benefit to doing some type of deltoid strengthening preoperatively in those that don't have the strength?
Yeah, I have done that for a few patients that I think are not, they're kind of waiting to get the surgery done. And I know that their deltoid's firing, but maybe not as strong, and I'll put them in PT. I just have a really conservative approach to almost all shoulder patients that come in, even those that have these chronic, tears. If they can forward elevate to, let's say, 100 degrees, and it's with ease, then sometimes I'll just put them in PT, and it's something that I can say, look, at any point in your life, when your function gets worse and worse, you come in and we'll take care of it. So a lot of times the patients are coming in and telling you, this is really affecting my activities of daily living, and what can I do about it?
Yeah, definitely. And I gotta ask too, what is the typical lifespan for a reverse total shoulder arthroplasty there? Are they lasting like 5 years or 20
No,
years?
we're usually saying 12 to 15 years, but that data is something that's continuing to progress because it's been around since the early to mid 2000s, and so that's kind of something that's changing. And I've been in practice 10 years, so I'm still, I haven't had any revise any of the ones for wearing out 10 years ago yet, so that's good. But we're gonna see more of that data coming out in the next several years, I'm sure.
Yeah, I'm also very interested to see how the revision surgeries come into being a part of that picture as well there, because I know for some of the other joints, it's been it's certainly been a hot topic, we'll say. So I'm interested to see how the revision for a reverse total shoulder kind of evolves there as well.
Yeah. And it is, like I said, it is an operation that's different than, a lot of operations we perform, because we're changing the anatomy in a way to kind of give a patient back their function and decrease their pain. So it's an amazing operation that really has kind of changed the game. Like I started with, it's really changed the game of shoulder surgery.
Yeah, definitely. Dr. Petruccelli, I know we've talked about so many different things ranging from rotator cuff tears and reverse total shoulder arthroplasty. Do you have any other kind of closing thoughts or closing remarks or anything we didn't discuss today that you really wanted to bring up?
No, I kind of would touch back on what we had talked about, kind of how I approach rotator cuff injuries and pathology, starting with the spectrum of just the tendonitis all the way to these massive tears. I really do. I know this is something that I already talked about, but I really do think that there is a role for physical therapy for a lot of these conditions. I think that when patients really kind of sit down and understand the anatomy and sit with their therapist and kind of understand the things that they can do to kind of make this better through the role of therapy, I think that it's a good first approach. And I think that when patients understand that and they're committed to doing that, I think it helps us as surgeons to say this patient wants to get better and trying kind of other options as well, which helps me then, when they fail those, treatment options, it makes me feel more comfortable that what I can do for them may be really beneficial. So I think, to kind of touch back on the beginning part of this conversation, I do think therapy is a great role in almost all of these rotator cuff injuries and situations. And yeah, there's still a lot out there to be done, and things are going to continue to change over the next 20 or 30 years, as they already have in the last 15 to 20.
Yeah, no, you're absolutely right. I completely agree there. Dr. Petruccelli, for people who want to find out more about you, maybe they want to find you on, social media. You seem like you're still in the MySpace generation. Or maybe they want to find out more about the Greater Washington Orthopaedic Group. Where can they find you guys at?
I'm not in the MySpace generation. I like that though. Friendster, you know what Friendster? It wasn't Friendster. Was that before MySpace? I can't remember.
Napster? I thought that was the music site.
No. No, I think it's called Friendster. You really never heard of Friendster?
No.
Okay. Now I'm showing my age. I'm not that old though. I've only been in practice 10 years. So my website for the name of my group is called the Greater Washington Orthopaedic Group, and our web address is www.gwog. So GWOG, it's very easy. gwog.com. That's our website, and then I have an Instagram page which is Doctor abbreviated, so DR and then Doctor Petruccelli. And my name is Petruccelli. So it's at Dr.Petruccelli.
Awesome. We will link to all of that in the description below. That way people can find out more about you there, give you a follow, and obviously reach out with any questions that they have or other things they might need for the shoulders. Or I believe you look at knees as well, correct?
I do. Yeah. Like I said, I'm sports medicine trained. My niche in terms of replacements is shoulder, but yes, I do everything arthroscopic, knee related. So I do a lot of knee surgery as well.
Awesome. We'll link to all that in the description below. Dr. Petruccelli, really appreciate your time and everything you've shared with us today. Thank you.
Yeah, Dan, thanks so much for having me. I really enjoyed it and would love to come back.
Hey everyone, I want to take a second and tell you all about AliRx. AliRx is a at-home food sensitivity and gut health testing panel. You order online and then receive and complete your test at home for food sensitivities. You then receive a custom report online through your member portal and then receive personalized recipes and supplements that are catered to you based on your food sensitivities. If this is something that interests you, you can check out the link and description in my bio, and you can use the coupon code capital D, capital B, RAUN, capital RX, so D Brawn RX, at checkout to save yourself 20%. Thank you so much for listening to this episode of the Brawn Body Health and Fitness Podcast. If you liked this episode, please make sure to share it with a friend, subscribe so you don't miss any of our upcoming episodes, and leave a review. This way we can spread knowledge and motivation and help reach more people. Thank you again for listening, and I'll see you next time.